The broadcast is now starting. All attendees are in listen-only mode.
Welcome to the PeriRx webinar, SaliMark OSC and Early Detection, the critical role of the oral surgeon. We appreciate everyone who has logged in to view this webinar. We are excited to share this information with you. Many of you are oral surgeons and are on the front line of dealing with oral cancer every day. Your input and feedback is very important to us. Our goal today is to speak about the early detection of oral cancer and introduce you to SaliMark OSCC. This test was specifically designed to help quantify the risk of oral cancer and help our referring practitioners make a more informed decision about early referral for consideration of biopsy of suspicious area or lesion. We want to work with you to make a significant impact on the morbidity and mortality of this deadly disease. At the end of the presentation, you'll be able to ask any questions that you may have by typing in your question in the box on the right of your screen. Also, we are supplying handouts with information from the various slides, as well as copies of our brochures. You can print or download them from the right-hand side of your screen under the Handouts section. And now, I would like to introduce Dr. Jack Martin, Chief Medical Officer of PeriRx.
I'd also like to thank everybody who's taken their time tonight to call in and log on for our seminar. So we're going to be talking about SaliMark OSCC and early detection. Specifically, we're going to concentrate on the role of the oral surgeon. By way of disclosure, I'd like to point out that I'm a co-founder of PeriRx, and I'm the Chief Medical Officer with equity in the company. Now, I think with this audience of oral surgeons, I think this information is probably well known to you that according to the National Institutes of Health, over 45,000 people will be diagnosed with oral cancer in the United States alone this year. More than 8,000 people in the U.S. will die of this disease. And very importantly, for the purposes of this discussion, the mortality has not significantly improved for this disease in decades. Everybody, I'm sure, is well aware that a major risk factor for oral cancer is smoking. 45 million Americans smoke tobacco, and there are also another 45 million former smokers of tobacco who are at risk for this deadly disease. Importantly, 25% of oral cancer patients who are often diagnosed in late stages of disease have no lifestyle risk factors at all, no history of tobacco or alcohol use or any other lifestyle risk factors for this disease. Unfortunately, approximately 2/3 of oral cancers are found in late stages, stages 3 and 4, often with no pain or other symptoms to alert the patient or their healthcare providers about the presence of this deadly disease. Largely to a consequence of late diagnosis, more people die of oral cancer each year than cervical cancer, melanoma, liver, kidney, testicular cancer, and Hodgkin's disease. Putting this into perspective, one person dies every hour of every day in the United States from oral cancer. The mortality of oral cancer goes hand in hand with the stage of diagnosis. This is data from the STEER data registry. And as you can see on the right-hand panel, that patients with localized disease have a much better 5-year survival rate than patients with regional or distant spread or unstaged disease. In the left-hand pie chart, you can see that unfortunately only 31% of oral cancers are diagnosed with localized disease. In part related to the late diagnosis of this disease, oral cancer is a very costly cancer to treat. Data projections from the SEER website indicate that by the year 2020, the cost of treating oral cancer, considering the initial and continuing care and care in the last stages of life, are expected to be over $5 billion. And this is not due to inflation because the blue and the green bars, the blue being the cost in 2010, are all calculated in 2010 dollars. It costs close to $100,000 on average to treat patients with oral cancer, one of the costliest cancers to treat, twice the cost of most other cancers. The majority of people treated are unable to return to work, so this absenteeism is an additional cost beyond the healthcare cost for this disease. And very importantly, if caught early, patients are more likely to be able to return to work, and there's good data showing reduced costs of healthcare in earlier stage diagnosis. So let's talk about the value of salivary diagnostics. To put it in perspective, oral cancer screening is a means of detecting disease early in asymptomatic patients. Positive results of screening exams are not usually diagnostic themselves, but identify persons at risk who warrant further evaluation. The SaliMark test is designed to be used to help identify patients at risk that warrant further evaluation, but it's not meant to be diagnostic in and of itself to replace a biopsy, which remains the gold standard for oral cancer diagnosis. If we consider other adjunctive screening technologies, such as mammograms for detecting breast cancer or pap smears for detecting cervical cancer, you can see on this slide that there's been a substantial decrease in mortality from breast cancer and cervical cancer sustained over decades after effective adjunct screening technologies were introduced. Even for prostate cancer, which is a less aggressive disease in general than breast cancer or cervical cancer, the presence of a biomarker screening test such as PSA has been associated with improved survival. This is in marked contrast to oral squamous cell carcinoma, where there's been no significant improvement in mortality in decades. Importantly, I'd like to point out that when we look at these other life-saving screening technologies, such as mammograms for breast cancer, the screening test itself is not designed to make a diagnosis of cancer. It's meant to identify people who are at increased risk that need to see a specialist for further testing, which may be repeat mammogram several months down the road. It may be a different imaging modality, or it may be a biopsy sooner. But the majority of people with these abnormal screening tests, although they identify the patients at increased risk that need more attention and help to diagnose these diseases earlier, the majority of people with these abnormal tests do not necessarily all have cancer. The salivary transcriptome, or messenger RNAs in saliva, were initially discovered in the laboratory by Dr. David Wong at UCLA over 10 years ago. And early in their studies, they compared the salivary transcriptome, or salivary messenger RNAs, to blood tests for distinguishing oral cancer from patients without cancer. The area under the ROC curve showed here is a measure of how much information content there is in your test. And you could see that the area under the ROC curve was better for the salivary biomarkers than for blood tests in detecting oral cancer. Subsequent to the studies conducted at UCLA by Dr. David Wong, the National Cancer Institute Early Detection Research Network conducted their own a study in close to 400 subjects to evaluate these biomarkers for oral cancer independently. They concluded that the validation of these biomarkers showed their feasibility in discriminating oral cancer. They also concluded that a prospective blinded trial should then be performed, and this was conducted by our company, PairRx, at the recommendation of the National Cancer Institute after their study, as the next necessary step to further validate the National Cancer Institute findings. In the prospective blinded study which we conducted, very importantly, 71% of the patients with cancer had T1 and T2 lesions. It has been a consistent finding across all of the studies with these biomarkers, including the National Cancer Institute Early Detection Research Network studies, as well as in Dr. Wang's prior work at UCLA, and in this prospective blinded study, that these biomarkers perform as well in early stage disease as they do in late stage disease. In this prospective blinded study, we validated all 6 of the pre-specified messenger RNAs in terms of their ability to distinguish oral cancer from benign disease. We identified and incorporated robust internal housekeeping genes into a highly discriminatory multi-marker predictive model for commercial use. Low-risk test scores, which were set at a cut point that had 96% sensitivity for detecting cancer, had over a 98% negative predictive value in what was a high-risk population in this trial that was conducted at tertiary care referral centers and their referring practices. The negative predictive value of any test is always going to be dependent on the population it's applied to. And in lower risk populations that don't have the 15% incidence of cancer that there was in our trial, the negative predictive values would be expected to be better. So, you're referring dentists and hygienists are the ones on the front line. The use of our test is really meant to be optimally applied after a patient is identified as being at concern because of abnormalities on the screening, history, and examination. An oral exam is taught as the gold standard of care in dental and hygiene schools, yet according to the National Cancer Institute, only a minority of Americans report receiving an annual oral examination. So the primary providers, your referring base on the front lines, must lead the charge because it all starts with a thorough history and physical exam. At this point, I'd like to take a slight break from this didactic lecture, and I'm going to ask the audience to respond to a question which is going to come up on your screen, which is, considering your top referring practitioners, do you think that they refer patients early enough? So I'd like you to take a minute to answer this question in terms of your referring doctors and whether or not you think that they're referring patients early enough who are at risk for cancer. So I'll just wait about another half a minute for everybody to finish voting, and then we'll show you what the results of this poll were. I have to show the results. Share results. So here's the results of the poll. Well, good. The majority of this audience, vast majority of this audience, think that their patients are referred early enough. Well, thank you for taking the time to answer that question. This was a survey that was conducted and published several years ago in the Journal of the American Dental Association, and it shows that 49% of primary care physicians reported performing oral examinations. Only 9% of medical physicians knew the 2 most common sites for oral cancer. And they concluded that the existing gap in knowledge and practices among physicians and dentists underscores the need to enhance oral cancer education amongst both professional groups. So it's our charge to oral surgeons that we need you to educate both dentists and primary care physicians on their role in leading the fight against oral cancer. As you can see on this slide, that dental clinicians actually referred in this survey less patients for suspicious oral lesions to oral surgeons than medical physicians, even though we know that many patients see their dentist more often than their medical physician, and the dentists are examining the patient's mouth at all visits. So, in terms of the value of SaliMark for oral surgeons, we hope that it can help facilitate early referral of at-risk patients from your primary care providers. And we also hope that this would help your primary care providers see a reason to do more thorough and frequent oral examinations. We also hope that it would help you in decision making in those patients where your determination as to whether or not to proceed to biopsy is unclear. And although the primary indication for our test right now is to help risk stratify patients that are identified on screening as being a potential risk for cancer, we would hope in the future that these markers can be used as we study this aspect further for potential surveillance of patients after oral cancer treatment. So at this point, I'd like to stop for a moment and ask the audience I was just bear with us for 1 second. I wanted to ask the audience to answer these two questions for us. Would you be comfortable speaking to your referral base about adding SaliMark into their oral screening protocol? I'll just give people a minute to answer that question, and then we're going to follow it up with one other question. Anybody voting here? 38%. Close the poll. Okay. So, majority of people feel they need more information. A minority of the respondents feel that they have enough information at this point. I'm going to put one other question out to the audience, and that is, do you see a benefit for a biomarker test that may be used to follow your patients after oral cancer treatment? Okay, everybody's voted, so I'll share the results. So I'm happy to see that the majority of people think this would be a benefit to them. So for your referring doctors who are on the front lines, there are limitations to the physical exam regarding their ability to distinguish which patients are at high enough risk to refer for potential biopsy. Patients who have chronic lesions such as leukoplakia and erythroplakia, the question arises, well, when has there been a change in this condition to the point where it warrants no longer following it, but sending the patient for a specialist for further evaluation and potential biopsy? So it's our thoughts that the SaliMark test could be used to help make this decision as to when somebody is at higher risk for some of these chronic lesions. So today, your referring doctors can implement this accurate, simple, and painless DNA test into their practices. They have the opportunity to change patients' lives through early detection of this debilitating disease and reduce disfigurement and potentially save patients' lives. The test was developed specifically to help quantify the risk of oral cancer after a concern is identified on a screening evaluation. The quantitative test result is a very effective tool for identifying patients at very low risk. As we discussed earlier, the negative predictive value, even in a high-risk population, was over 98% and would be over 99% in most screening practice scenarios. And at the same time, it identifies patients that are at increased risk who would most benefit from earlier referral. To put the performance of our test in perspective, I'd like to talk about the other biomarker tests that we mentioned earlier when we were talking about cancer screening technologies. And let's talk about PSA, which has been around for decades and is widely accepted as a useful tool in the right patient in the right patients. You have to go back to studies that are several years old where they biopsied everybody in spite of the biomarker level, even if it was low, in order to generate this kind of data in terms of false negatives. But PSA has a false negative rate of over 15%, even after 7 years of repeat testing with 7 repeat negative PSAs, and even after excluding high-risk patients with abnormal rectal exams. In another study also published in the New England Journal of Medicine, where everybody was biopsied regardless of the PSA result, you can see the sensitivity of PSA was 79% with a specificity of 59%, positive predictive value similar to what we had in our clinical trial, but negative predictive value not nearly as high. So we could conclude that the sensitivity and specificity of SaliMark, as well as its negative and positive predictive powers, compare very favorably to PSA. Given that oral squamous cell cancer is a much more aggressive disease than prostate cancer, we believe that the primary provider decision for a referral to a specialist should be based on test scores that maximize sensitivity in the high 90s. We don't think that the 79% for PSA is adequate for this more aggressive disease. So the superior predictive accuracy of SaliMark is based on over 10 years of National Institutes of Health funded scientific studies, with over 900 patients now studied in the SaliMark program. A multi-marker model utilizing 3 cancer genes to maximize performance as compared to a single marker test is what gives this test its discriminatory value. SaliMark OSCC low-risk test scores are a very strong predictor of freedom from cancer, and high-risk test scores in our clinical trial were associated with a 2 to 3 times increased chance of oral cancer. So we believe that the test is indicated after an at-risk patient is identified on screening examination, and it can help the doctor make a more accurate decision on whether to refer the patient on to a specialist for consideration of biopsy. If your referring doctors are comfortable using adjunct visual aids, we don't discourage that. We don't consider that to be a competitive technology to our biomarker test. We believe that no matter how a suspicious lesion might be identified, if the practitioner is unsure as to whether or not they should follow this patient or if it's time to refer this patient, that our test can then be applied in these patients as well after they have a lesion identified with a visual aid. And just to summarize some of the points that we've made in the presentation, the SaliMark biomarkers were independently validated by the National Cancer Institute Early Detection Research Network, which is not true of any of the other adjunctive screening technologies. It was specifically studied in an intended use population of patients with oral lesions. It was specifically designed to quantitate the risk of malignant versus benign oral lesions. It incorporates markers into a single quantitative test score to increase the predictive value. And importantly, it was studied in prospective blinded trials as recommended by the National Cancer Institute after their case-controlled studies were completed. So how would we advise the practitioners in the front lines to use this test? Well, if they have a patient where there's a concern and they're not sure how high that concern is, they could do our test. We believe that the decision for the primary care provider who doesn't see oral cancer with the same frequency as specialists, we believe that their decision should really be based on whether it's a low-risk test score, at which point we then recommend that they follow the patient, because no test can be perfect. Even a biopsy is not 100% accurate if you biopsy the wrong lesion. A low-risk test score puts a patient in a category where there's a very, very small chance of cancer, but the patient should still be followed up. And we believe that at the primary care level, anything that's not a low-risk score should be referred out to a specialist. So their decision is really a binary decision, yes or no. Low risk, follow the patient up. Anything other than low risk, refer the patient out. Our test gives a continuous score from 0 to 1 with 2 decimal points. So for those people who like to think about 0 to 100, you could just eliminate the decimal point. But it gives an actual quantitative test score, and we help divide that into moderate or high risk. We believe that the decision about whether or not to proceed with a biopsy or to follow the patient for moderate and high risk scores is best to be in the hands of an oral cancer specialist who would take the test score into consideration along with their history and physical exam to make an individualized decision. So how is the test actually used in the office? Everything that you need to perform our test is included in one box, which is shown here in the left panel. For ease, the instructions which you see on the right side of this slide are also on the inside cover of our box. The box contains everything that you need. The patient simply needs to rinse their mouth with water, and then they spit into a funnel, into a collection tube, until they've collected 1 to 2 mLs. The funnel is then discarded and the tube is capped. The tube then you have to shake the tube a few times in order to dissolve the biomarker preservative that's in a dried pellet at the bottom of the tube. The saliva will change color when the pellet dissolves. You record the patient's name and date of birth on a label, put it in a biohazard bag. The patient is registered for the test through a HIPAA-secure link to our laboratory, and everything is done electronically in the office on a computer to register the patient for the test. The biohazard bag and a barcoded requisition that gets printed out of the computer when the patient is registered get placed in the envelope and then shipped with a prepaid FedEx label to our laboratory for analysis. Beyond just the saliva collecting, in terms of the steps to become a user of our test, you order the test kits from any one of a number of national distributors as well as from our website. You register your practice one time on the website to become a SaliMark user. You can order educational brochures from our website and review coding and insurance information that's provided. Once you identify the patient, you follow the instructions that I just showed you on the test kit. After you register the patient, as we talked about on the HIPAA secure website, you select a payment method where either the practice or the patient pays for the laboratory analysis. You print the barcoded laboratory requisition and place it in the envelope as I showed you and call FedEx. And importantly, within 72 hours, an email would be sent to the practitioner advising them that the test results are available, and those are accessed through the HIPAA secure link to the laboratory information system. And you can review how to read a test result and interpret it on our website, but this information is also provided in the laboratory test report. Now let's just talk briefly about the fee structure for this test. The test kits are sold in boxes of 10 for $199.99, so it's about $20 per test kit. And then the question comes up, well, what does the practitioner charge for their administering this test? We don't set the practitioner fee. We feel that the practitioner should set their fee for what they charge for the examination of this patient where there's a concern for cancer, and then doing the test, checking the results, and counseling the patient. They should bill the patient based on what they think is usual and customary for the time that they spent. The laboratory analysis itself is $180, and as we talked about, this fee could be paid by the practitioner to then bill their patient to collect that fee from the patient, or the patient themselves could pay for the laboratory fee, and that's all done through our website. And then it's important to discuss how to submit for reimbursement for this test. Well, very importantly, for medical reimbursement, you have to establish the right diagnostic code using ICD-10 codes, and information on the potential diagnostic codes to justify the test are available on our website. The laboratory service fee for performing the test can be submitted for reimbursement under medical insurance. The medical code 81599 is for a multi-analyte assay, which is an assay that takes several markers, as we do, and puts it together into one test score. And that's the CPT code that patients can submit to medical insurance for potential reimbursement for the laboratory fee. The dentist charges can be submitted for reimbursement by the practitioner or the patient using either dental or medical codes, CPT or CDT codes that exist. And there's detailed information on our website about the various CPT and CDT codes that can be used depending upon the level of service that the practitioner feels they provided. And we also provide ADA and CMS claim forms on our website. So our charge to oral surgeons, and we hope that this group is willing to take on this charge, is to educate your referral base about the importance of oral cancer screening, to educate them about early detection and the potential use of SaliMark in their screening protocol to help risk stratify these patients where the decision about how to proceed is not clear, and for you yourselves to use SaliMark when you are uncertain about the best course of action in certain patients with lesions of concern. In order to help educate your referring base, we have a number of items available on our website. This includes brochures for dentists and hygienists as well as for patients. Our website has a large number of scientific studies on the science behind this technology. There's a webinar available to your referring practitioners that actually gives 3.5 CE credits for people who take the webinar and do the other supplemental educational activities that are associated with the webinar. And we have a customer support that's readily available through our website. So the fight against oral cancer has to be a team effort. Together, everybody can achieve more. I apologize to people who don't live in the Philadelphia area for showing our Phillies, who we hope over the next few years have a comeback and do better. But really, the primary team members in the fight against cancer are your referring doctors and hygienists out in the front lines, as well as you, the specialists, the oral surgery specialists. And we would like to be part of your effective team by providing this advanced molecular technology that we hope will be a benefit for risk stratifying your patients. So thank you very much for your time. The ParaRx website is listed here. You can also send any questions to info@pararx.com. Our office number is listed here. We have hygienists in our office that are available to speak to people with questions, and I'm available to people who have additional questions regarding scientific or medical issues related to this technology. And at this point, we'd like to open it up to questions from the audience. You could type in your questions on the panel on your screen. So we have, one question, and this is a commonly asked question. We get this a lot. Well, how about patients who have this test done and there is no visible lesion in the patient? Well, the primary indication for our test is in a patient where there is a suspicious lesion. Since we've been in the marketplace, we've seen a number of practitioners who chose to do this test in their high-risk patients that have been heavy smokers and drinkers. In some circumstances, it came back low risk, and those patients are just counseled about their habits and seen for routine follow-up. And in some patients, it came back high risk, and the practitioners in some circumstances chose to send the patient to a specialist to be sure that they didn't miss something on their examination. And in other circumstances, they were fairly certain they hadn't missed anything, but they put that patient on increased surveillance to be seen back sooner. A similar question was, what if the test is positive and you can't find a lesion clinically? that's sort of the question I just answered. If you're uncomfortable with your exam and you want to send this patient to a specialist who sees oral cancer much more often than you, that's one option. The other is to see the patient back in earlier follow-up. Another question is, well, if there's a suspicious lesion, why not do a brush biopsy, which has good sensitivity and specificity? Well, that's a good question. So there's a couple of issues here. I think I tried to point out in this presentation, we're not intending for this test to put any other adjunct out of business and replace any other adjuncts that people feel comfortable with in certain circumstances. We feel that we're just another important tool in your toolbox for the right circumstances. So if there's a lesion and you do a brush biopsy, the question is that if it's a diffuse lesion, did you test the right spot? That's one concern. The other is, did you get deep enough? If you're somebody who's comfortable and feels that you know how to do a brush biopsy accurately, and you feel like you're getting a deep enough sample, but it's user dependent in certain circumstances. The other issue is, and I should point out, our test is not dependent on identifying a particular region. You're just collecting whole saliva. So in the primary care provider's hands, there's much less expertise required. In somebody who's experienced with doing brush biopsies, the result you're going to get back is either going to be dysplasia or no dysplasia. It doesn't really make the diagnosis of invasive cancer. So if there's dysplasia, the patient's going to need another incisional biopsy anyway to make a definitive diagnosis as to whether or not it's an invasive cancer or not. So again, we're not trying to put other adjunct devices out of business. There are certain practitioners who are not going to be as comfortable with doing a biopsy. So again, I have this question, another question, that the brush biopsy can show squamous cell carcinoma. Well, again, it depends on getting into the right layers and making sure you didn't miss the right cells and you biopsy the right place. So if people are comfortable doing brush biopsies, we're not asking you to stop doing it. We're hoping that our test will get patients to refer these patients, to get people on the front lines to refer these patients to you sooner. And if in your particular practice you think a brush biopsy is an important adjunct tool before a scalpel biopsy, again, we're in favor of people using all tools that can potentially help them to identify this disease earlier. Another question that we get, that we have here, and it's a commonly asked question, is how about dysplasia? Can the SaliMark test detect dysplasia? I have to tell you that the National Cancer Institute study did not study any patients with dysplasia because it was a case-controlled study and they had all invasive cancers and then normal controls. In our prospective blinded study, which is ongoing, by the way, to generate more data, but in our prospective blinded study, we had all comers with all sorts of oral pathology, and the majority of patients with dysplasia had moderate and high-risk scores on the SaliMark test. One other question that I got is, are there other tests in the pipeline? So the SaliMark test for oral cancer is the first of a series of tests in saliva that our company plans on coming out with. The oral cancer markers are the most advanced of our portfolio, and that's why it's in the marketplace. We have patented biomarkers for lung cancer detection that were studied at UCLA in a relatively large case control population, and we have almost completed enrollment in a prospective blinded study where saliva is being collected in patients with lung lesions before they go on to biopsy. So again, a prospective blinded study, and we should be done with enrollment in the next 2 months and have results of that by the end of the second quarter of this year. And the issue with lung cancer might be, well, what does it have to do with the oral practitioners? Well, a lot of your patients are smokers, and those are the people that get lung cancer. And we do think that there's a role for oral practitioners screening their smokers for a test that might tip you off to the fact that they need a CAT scan for potential lung cancer detection. Another question is that the accuracy, that someone had read that the accuracy of our test is 85%. Is that correct? Well, accuracy consists of two different components. It has to do with how many true positives you have and how many false positives you have are both part of accuracy. Because this is not meant to be a replacement for a definitive scalpel biopsy for definitive diagnosis, for reasons we talked about, we prefer to have this test where we decide on low versus higher risk at a sensitivity of 96% because we want to minimize the chance of missing oral cancer due to the aggressiveness of this disease. So the sensitivity is set at 96%. At that high level of sensitivity, the specificity is between 50 and 60%. So the overall accuracy is in the range that is being projected here. But again, it's important to talk about, are you talking about the sensitivity and how many cancers do you detect, or are you talking about the specificity and how many times you say there could be a concern and it's not an invasive cancer? And the reason I showed the data, which I did on mammograms and pap smears, is these tests are known to be life-saving tests. There's no question about it. They've been around for decades. And actually, the sensitivity and specificity pairs, you always have to look, whenever you make a test more sensitive, you always have to sacrifice specificity. That's just the way it is for any test. The sensitivity and specificity pairs for our test really compare very favorably to other adjunctive tests. But again, we try to favor being very sensitive because of the aggressive nature of oral cancer. Okay, I just want to remind people about the handouts that are there for those people who want to print them out. And I don't think there are any other questions from the audience. So I really, once again, appreciate everybody's attention and for taking your time tonight to log into this webinar. And again, we're available through our contacts and information at PeriRx and through our phone number. And we're happy to hear from anybody and discuss anything in more detail with any other questions that they have. And at this point, I guess we'll be able to log off and thank you once again.